Understanding the history of this unique field is not merely an academic exercise. It is an essential component of competent and compassionate practice. The journey of mental health nursing is a long and often turbulent one, reflecting society's evolving perceptions of mental illness itself. By studying the past, we gain invaluable context for the present, understanding why certain protocols are in place and why specific patient rights are so fiercely protected. This historical lens reveals the progression from custodial containment to therapeutic engagement, highlighting the profound shifts in philosophy that have shaped the modern standards of care. This knowledge is not just for context, it is directly applicable to navigating the complex ethical and legal scenarios presented in clinical practice. The National Council Licensure Examination, or NCLEX, places a significant emphasis on the principles that grew directly out of this history, particularly those concerning professional standards and fundamental patient rights. In the distant past, societal understanding of mental illness was shrouded in superstition, fear, and profound ignorance. Conditions that we now recognize as clinical depression, schizophrenia, bipolar disorder were frequently misinterpreted as demonic possession, a divine curse, or a fundamental moral failing. Individuals exhibiting symptoms were not seen as sick, but as willfully deviant or supernaturally afflicted. This deeply flawed perspective meant the response was not compassion or treatment, but ostracization and punishment. This pervasive misunderstanding gave rise to the asylum, initially conceived with benevolent intentions to provide sanctuary. These facilities quickly devolved into little more than human warehouses. The primary objective shifted from healing to containment, from therapy to control. People were locked away from society, often for life, with little hope of recovery or reintegration. The methods used to manage behavior were rudimentary and often brutal. Physical restraints, shackles and straitjackets were commonplace, used as a first-line tool for managing a misunderstood population. Within these imposing walls, the concept of treatment was virtually non-existent. While patients were provided with basic shelter and food, which was an improvement over homelessness, their psychological and emotional needs were almost entirely ignored. The environment was sterile, impersonal, and regimented, designed for the convenience of the staff rather than therapeutic benefit. Meaningful therapy or engagement was exceedingly rare. The prevailing belief was that these individuals were incurable, and so the focus remained squarely on custodial care, keeping patients fed, clothed, and most importantly, segregated from the general public, thereby reinforcing the stigma that they were somehow less than human. This era of institutionalization, while dark, laid the groundwork for future reforms by making the consequences of neglect and misunderstanding starkly visible. While not exclusively a psychiatric nurse, Florence Nightingale's contributions to nursing established a foundational paradigm that would profoundly influence mental health care. During the mid-19th century, she championed the revolutionary idea that a patient's environment was a critical component of their healing process. Nightingale meticulously documented how factors like fresh air, sunlight, proper nutrition, a calm, orderly setting could dramatically improve patient outcomes. This environmental theory was a radical departure from chaotic, unsanitary hospitals and asylums of her time. Her emphasis on holistic well-being set a crucial precedent that healing involves more than treating a specific ailment. It requires caring for the whole person in a supportive setting. Decades later, Harriet Bailey took a monumental step in codifying psychiatric nursing. In 1920, she authored the very first textbook, Nursing Mental Diseases. The book provided the first structured curriculum for nurses working with mentally ill patients. Prior to Bailey, education was inconsistent and often anecdotal. Her book armed a generation with a common language, defined theoretical concepts, practical skills for assessment and intervention. It legitimized psychiatric nursing as a distinct specialty, moving it away from custodial work toward professional practice. Perhaps the most influential figure is Dr. Hildegard Peplau. Peplau's theory of interpersonal relations, 1952, shifted focus from doing to patients to doing with patients. She framed the nurse-patient relationship as a dynamic, goal-oriented partnership with phases: orientation, identification, exploitation, resolution. Peplau taught nurses to use the therapeutic relationship as the primary vehicle for healing, using communication, trust-building, self-awareness. NCLX. Type P. When a question involves Peplau, think phases of the nurse-patient relationship, therapeutic communication, use of anxiety to promote learning and growth. The mid-20th century marked a pivotal turning point, initiating a massive systemic shift known as deinstitutionalization. For over a century, the primary model of care had been long-term confinement in large, state-run psychiatric hospitals. The first and perhaps most significant catalyst was the development of the first generation of psychotropic medications, particularly antipsychotics like chlorpromazine, Thorazine, in the 1950s. These drugs offered a way to manage the most severe symptoms of psychosis, making it conceivable for many individuals to live outside institutions. Simultaneously, public and political awareness of abysmal conditions in state asylums grew. Journalistic exposés, first-hand patient accounts, advocacy for mental health reformers, painted a grim picture of overcrowding, neglect, human rights abuses. This generated public pressure for reform. States also faced powerful financial pressure from the cost of maintaining massive institutions. A new legal emphasis on civil rights and patient liberty emerged. Activists and legal scholars argued that unnecessary confinement violated constitutional rights. Landmark court cases established the right to treatment in the least restrictive environment, meaning care should preserve freedom and autonomy. The cumulative effect, new medications, financial pressure, public outcry, legal mandates, push momentum away from the asylum model. Deinstitutionalization aimed to transition patients into community-based services. The planned smaller local clinics, outpatient treatment centers, halfway houses, home-based care services. The shift toward community-based care, it wasn't just philosophical. It was codified by landmark federal legislation, the National Mental Health Act of 1946. It established the National Institute of Mental Health, and it provided federal funds for research, training of professionals, grants for states to improve mental health services. This signaled a new federal commitment to mental illness as a public health issue. The Community Mental Health Centers Act of 1963, signed into law by President John F. Kennedy, it authorized a nationwide network of community mental health centers, inpatient care, outpatient care, emergency services, community education. This formed the backbone of the new care model. These legislative acts shaped modern care, but it was the evolution of case law that defined patients' rights. A core principle is the right to treatment in the least restrictive environment. A patient's liberty should be curtailed only to the minimum extent necessary for safety. Example, a patient who can be safely managed with hourly check-ins in an unlocked unit should not be placed in seclusion. NCLEX tip: when presented with a behavior scenario, choose the least restrictive intervention that ensures safety. Consider verbal escalation, avoid physical restraints when possible, and avoid chemical restraints when possible. Another cornerstone is patient autonomy. Patients have the right to accept or refuse treatment unless legally deemed incompetent. And this is tied to informed consent. The patient must understand the proposed treatment, understand the risks, understand the benefits, understand alternative options, and the agreement must be voluntary without coercion. This protects against historical forced and uninformed treatments. These foundational laws and rights form the ethical and legal framework for every mental health nurse. They represent a deliberate break from paternalistic, coercive models of the past. The NCLEX heavily tests these non-negotiable standards of care. Test questions often present a clinical dilemma requiring the action that best upholds patient rights. Right to refuse treatment, right to confidentiality, protected by laws like HIPAA, right to be treated with dignity in the least restrictive setting possible. In summary, the evolution of mental health nursing is a powerful story of transformation, moving from a history rooted in custody and control to a modern practice centered on collaborative care and empowerment. The early era, defined by asylums, was characterized by societal fear and a custodial approach that offered safety but little hope for recovery. The paradigm began to shift dramatically thanks to pioneers Florence Nightingale, who underscored the importance of a healing environment, Harriet Bailey, who established a formal educational foundation, Hildegard Peplau, who revolutionized the field by centering the therapeutic nurse-patient relationship. This progress culminated in the deinstitutionalization movement, which relocated care into the community and was supported by laws protecting patient rights, mandating the least restrictive care, and cementing the therapeutic alliance as the cornerstone of practice.